Greetings and welcome to the International Pediatric Simulation Society podcast. This show is for people passionate about pediatric simulation-based education, training, and research. Podcast hosts are members of IPSS, a global community of multidisciplinary healthcare professionals from over 30 countries, all dedicated to improving the care of infants and children worldwide. Each week, one of our sub-hosts, Christine Bailey, Elaine Ng, Aaron Karn-Bennett, and myself, Samreen Vora, will introduce you to a new guest and bring you into a conversation with simulationists and healthcare professionals from across the world. Come along. Excited to be back with another episode, and on this episode, we speak with Dr. Jennifer Arnold about her keynote address at IPSSW 2024 entitled Enhancing Patient and Family-Centered Care Through Simulation. Dr. Arnold has been involved in simulation for over 14 years, with experience building 2 pediatric simulation programs. Her areas of focus within simulation include use of simulation for evaluating new clinical spaces, team training, improving quality and patient safety, and improving home care and skills for primary caregivers of children with medical complexities. Stay to the end of this episode to hear her share the intersections of her very personal experiences. And make sure to join us for the upcoming IPSSW 2025 in Munich, Germany, where you may be able to sneak in your very own one-on-one conversation with her. Hello. Welcome, Dr. Arnold, to IPSS, the podcast. We're really excited to have you and to just chat with you about your keynote address that you gave at IPSSW in Denver in 2024. And the title of your talk was Enhancing Patient and Family-Centered Care Through Simulation. And I will tell you, I loved your talk. It was just really moving and really centered us on, for me at least, why we do simulation. Sometimes we're on the educational side of sim, we're doing sim for trainees or we're doing sim for healthcare professionals, and sometimes don't see all the way to the bedside of our impact. And I always remind my simulationists, my staff, we are saving lives when we do simulation in all the capacities. So this was really cool to hear you talk about enhancing patient and family-centered care using simulation. So welcome first. Hello. And yeah.
So excited
Yeah.
hosting this amazing podcast, and thank you for inviting me.
You're welcome. I know everyone will be really excited to hear this episode with you. So I wonder if you could start by giving us a little synopsis or summary to what you spoke about during your keynote.
Yeah, so this this particular keynote was about one of my passions in healthcare simulation. I think many might know I've been involved in the field now a long time, most of my entire career, it seems. And so I love all aspects of simulation, but this one in particular is one that I've been very passionate about. And that's the concept, like you said, of sort of directly applying simulation to help impact in a positive way our patients and families, right? That's all why we went into healthcare, why we went into this field, is we want to make a difference for our patients and their caregivers. And so this topic is just near and dear to my heart. And one of the things that I also enjoy doing is sort of, probably because I like to organize everything in my life, including my pantry, is I like to think about frameworks. And so in this talk, I tried to kind of conceptualize a framework for how we might apply healthcare simulation to support patient and family-centered care. And everything from the actual patient outcomes and safety to the experience of patients and families. And so really, I came up with a framework, which is, sort of in total 6 different ways we might think about or apply healthcare simulation as a mechanism, a method, a tool for enhancing patient and family-centered care.
I love that. Even your pantry, you like to be organized. I feel like part of that is your neonatologist brain, like detail-oriented, get things organized. I think it's amazing to take this topic that maybe sometimes people don't think of in that depth and breadth and provide a framework to say, look, this is ultimately our goals is to improve patient family-centered care and outcomes and experience and kind of all of these pieces. But what are those pieces? Do you want to speak a little bit more about that framework and high level of what those kind of 6 different ways were that you were thinking about this?
Yeah. So, basically, not that the names are necessarily all in the literature. We need to grow the literature in this area. But I sort of thought of, the different ways either I've utilized simulation in this space or others have, and sort of tried to come up with terminology so that we can, again, categorize and then think about what are the goals and then subsequently what approach might be best to meet those goals. And so the first category is sort of the idea of patient prep, right? So it's using simulation to help prepare patients and or caregivers for care in the hospital. Here at Boston Children's, that's something that the team here has been doing for quite some time with a program called Sim Discovery. And so it's this concept of, for example, patients undergoing spinal surgery, very complex surgery. We bring a cohort of families in who have upcoming surgeries, and they get to go through different rooms and experience what is the pre-op experience like? What is the OR experience like? And then how do we prepare for care at home? Like, what are the things to do? And, not only does it help to decrease anxiety, but it also can help with just ensuring that outcomes are better because patients are prepared for, this is how I have to get out of bed now after my surgery. And they actually get to practice that so that muscle memory exists before they have to do it, when they're in pain and post-op. So that's the first category, what I like to think of as sort of patient prep. And then patient therapy simulation, which is this concept of using simulation as a tool to improve actual care, right? So if you think about things like VR experiences, that's been utilized in many institutions across the globe where, kids or adults might be going through a VR experience to help decrease pain, the need for analgesia or other medications. And so, that's actually part of the therapy that a patient might be experiencing real time and thinking about the different sim tools in our box. The third is patient-driven simulation, and this is the concept that simulation is being driven by patient and family needs. And so this is what I typically have been mostly involved in my career, which is creating simulation training curriculums to help prepare for care at home or out of the hospital so that our patients have a better chance of better outcomes, maybe decreased readmissions, less morbidity, mortality, and hopefully less anxiety in terms of care at home. So, a child with a tracheostomy and ventilatory support, the caregivers can come through simulation both for routine skill-based training, but also those emergencies that they may exist. And, it's always, I think, the thing that's always powerful to me when I sort of just try to describe this to a simulationist is, if a patient were to have an emergency in the hospital, like a blocked tube, we're not going to say, okay, mom and dad, you take care of this, or, caregivers, because you're going to have to be prepared because this is very likely or potential to happen at home, and sit back and give them feedback, right? No. We're going to step in and do it. So without simulation, there's no way for our parents and their home caregivers to be able to have that opportunity to practice. And that could be the difference of saving their child's life, which is a burden no parent should have to, or caregiver should have to do. But unfortunately, that can happen.
Can I pause you, Dr. Arnold, on the first? Let's talk a little more about the first 3, and then we can maybe move into the next 3. Is that okay? It is a lot, right? I mean, I love it. I have so many thoughts. And I know my first introduction to this area was really through you when you were doing some just really innovative pioneering work, kind of in that third bucket that you talked about, right? Caregiver simulations. And we were able to really look at your work, learn from your work, and then build some of that at, some of the other institutions I've worked at as well. And so just kind of focusing on these first 3. I also love that you said there isn't a lot of literature. We don't know a ton. And so we need to learn more in all of these areas. So that first one, you talk about patient prep simulations and thinking about what's in the literature. I remember learning, not even in sim or healthcare literature, but just in general habit building literature. I remember reading some books about habit building. And when you actually do those things, especially for like recovery, they had looked at people who were having hip surgery. And this is even next level from what they looked at. They looked at having someone just know that they need to do recovery and telling them, compared to someone who you told them they created a plan. of what they were going to do. Like, where were you going to walk to so that you had movement in your day? They recovered significantly faster and went back to being able to move around and baseline after a surgery. And so now we're taking that literature and thinking about, man, we need to do some research on what happens when you take it even to the next level, where they get to, like, before their surgery, not just create a plan, but practice the plan and know what's going to, like, think about, okay, like, we're going to build some muscle memory after the surgery. And so they're mentally prepared for that. So that's really cool, thinking about where that sits in the literature. And then you talked a little bit about patient therapy. I mean, I was just at a talk about VR, especially for pediatrics, and how it's used. I think there's just so much potential on really moving the burden. We think about how we use sim for trainees, and we used to have a model where it was like, hey, you see one, you do one, and then you teach one, and we realize, ooh, that's not safe for our patients. Similarly, in this space for our patients and using it for patient therapy and having VR available to have experiences where it can reduce pain, and there's so many other potentials where we can really lighten that load of our patients in so many spaces. And then the third one is really, like I said, where we've learned so much. You were a pioneer in this space of caregiver simulations. And one of the things you mentioned, decreasing admissions. So I know our hospitals and our healthcare providers and our organizations and systems care about that. And then you mentioned less anxiety for our caregivers. And sometimes our systems feel like they're not interested in that. But I think research shows that it not only alleviates their anxiety, but has better patient outcomes just by relieving their anxiety. No parent, no caregiver should have that burden if there is an emergency, that anxiety that I might be the reason my child dies. I mean, how horrible to have to carry that. And if simulation can alleviate that, I think in your talk, you talked about they come in and they do these simulations, and it's not that they are like, oh, I just learned the skill. It's that they say, hey, I didn't realize I knew this skill, and now my anxiety is less. So I don't know if you want to speak a little bit more to that and kind of your experience in that space.
Yeah, no, I think the anxiety piece is huge. And I think one of the things that we've been trying to do is to measure that. What is that? Again, thinking about, can we show demonstratively that it's decreasing anxiety? And what does that then mean for our patients' satisfaction, their ability to provide care at home? I mean, not to take this on a personal level, but, this is so personal, as I've been a patient my entire life. And I wish that I had had experiences for simulation, even as an adult with medical, complexity. Like, as a neonatologist, I placed PICC lines in babies, right? And then I ended up with cancer, and I had a PICC line placed. And the first time I had to go home and scrub my hub and flush my line, like, I had anxiety. It took me and before I left, I mean, I know how to do it theoretically, and I've seen. That I was taught briefly, like basically just a little verbal instruction about what to do. But when you're doing it and it's like your loved one or your life on the line, you're like, the last thing you want to do is make a mistake, make a misstep. And so if you simulate, like, I wish I had simulated, because then it would have been like, oh, got this. Like, I did it. I got feedback real time from an expert. And now when I'm home, that anxiety is way less, and I'm less likely to make mistakes. Again, I don't know if that answered your question, but I think
definitely.
It's so important. Like, why would we not give these same benefits that we experience as healthcare clinicians to our patients and families?
Our patients' families. No, 100%. I think that totally answered. And more than a question, it was just even you sharing that personal experience. I think we don't realize until we have to change hats. And so the fact that you bring that experience and you're like, gosh, when I was a patient, even knowing that I was a healthcare professional, it's totally different. And I think we forget that, for us, it's a day in the life. You go in, you put a PICC line, and they have to go home. And it might even seem simple, but we forget that we have all these, we have teams and lots of people in the hospital, and someone to go home and on their own do that. There's a lot of anxiety involved. And the real-time feedback, I think simulation, we talk about when we've used sim in other areas, the debriefing, the feedback, that's key. And I think sometimes we might be nervous to do that in the patient-facing or the family-centered space. But what you found essentially is that it's critical. It's actually super helpful to be able to get real-time feedback, even for our families. Like, not surprising, but at the same time, we're like, oh yeah, okay.
Exactly. Like, I'm like, okay, either I do know what I'm doing, or I should have done that a little differently. But I'd rather learn that lesson in simulation than when I'm home on myself.
When you're at home. Yeah. And can't ask anyone. I love that. And so that's critical. So, I mean, this space, I could talk about this forever, but I want to make sure we get to your next 3 things that you had kind of highlighted in your talk. So if you want to start sharing those, that would be great.
Yeah, absolutely. So the next topics are a little bit, slightly different, but still in the category of patient and family-centered care, and that is patient-directed simulation, which this to me is something that many of us, I think, are doing more and more of, or we've been doing for quite a while in healthcare simulation, which is the idea of engaging patients, caregivers as authentic voices and partners co-creating simulation activities. So typically, maybe it's related to education, but it could really be applied in any of the applications of simulation, for healthcare systems, for clinical care, for training. But parents are and caregivers or patients are part of that. Those experts, right? They're the content experts. So, for example, if you're training on how to maybe discuss difficult news, a new diagnosis, or something else, maybe involving patients and families to help us with what are the things that we can do that make that the best possible, and getting their perspective and creating those objectives, everything from objectives to scenario situations, and then potentially even debriefing. And not that I've done a lot of debriefing. I've really only done debriefing with patients and family members in the system simulation work, but I know that others have done this in the educational side, and that can be so empowering to have them be giving us feedback as clinicians. So it helps us as clinicians do better work because our parents and patients and families, trying to be all inclusive, are giving us feedback and helping to drive that education. So that's directed, right? Thinking about them directing it. The next one is patient-specific simulation. And this is the idea that we are utilizing the tools of simulation, our toolbox, to improve patient-specific care. So that could be the concept of doing simulation-based clinical rehearsals. So again, for a unique patient, maybe we're preparing for a surgical separation of conjoined twins, and it's very, very unique to that patient, even including the family. We simulate it. I've done this before, but we've actually included the parents in that simulation, rehearsed how we're going to update them during it, got their feedback during the live simulation, but also it helped those clinical teams really rehearse and identify potential hazards, flaws, challenges, make, final, confirm decisions that they had already anticipated in terms of plan of care by rehearsing it for a specific patient that has unique or complex clinical needs. And then the last combination, which is to me very new and warrants a lot more work to be done, is the idea of patient EDIA simulation, which is equity, diversity, inclusion, and access. So sort of thinking about how, and this is a little bit more of a complicated, which if you'd like to deep dive, it has sort of sub frameworks, because you know me, that framework person, of how we can partner with patients and families to improve equity, diversity, and inclusion, and particularly related to disability competent care in our healthcare organizations. They are the experts, right, when it comes to this. And so figuring out and thinking about how we can partner with them to make our health systems more accessible, more equitable, only helps us provide better care.
Man, I mean, I love that you love frameworks. It's not just have all the right things in the right places in your pantry, like your cereals here, your spices here, but like have your spices alphabetized is kind of what I'm hearing, right? I love that. But these frameworks are really helpful to think about how do we break this down to really get at each of these. And so now the next 3 you've talked about, you started with the patient-directed sims and co-creation of sim activities. I mean, again, this is one of those concepts where it's almost like we should do that, but we didn't for some time. I mean, I say we in a global sense, and maybe, of course, there are some folks that were maybe further ahead on this and already did, but a lot of folks didn't. And so it's really important to articulate how impactful it is. And it's across the spectrum, not just creating the sim activities, but even including them in debriefing. And you said it helps us do better work. And I 100% agree. Speaking of feedback, why not get feedback literally from the end user to then get better at what we do? And the example of potentially using simulation, for example, when we do communication sims, I know of places where breaking bad news or disclosing death, they've had families that have experienced that be part of the sim, but in a way that's trauma informed and really mindful of not increasing the burden that family or that caregiver person carries. And so I've seen it done where they'll have them be observers in a sim and then participate in the debrief, giving them the autonomy of where do they feel the space of being able to participate and not increase the burden of trauma or re-traumatization. And so I think that's a really important factor as well.
I agree. And that's something that, again, all of these, but particularly this sort of application, I think it's so important to be really thoughtful, engage other experts in your organization that are experienced, whether that's child life, social work, clergy, or, your chaplain services, all of the different psychosocial supports that we have to help ensure that we are doing this with a trauma-informed lens, and that we're supporting the family members, the caregivers, the patients who are participating as well, because we wouldn't want to cause secondary harm.
I think that is just so, I feel like worth saying more than once, engage those folks that really have experience. I speak for myself really as a physician, sometimes to take that hat off and remember, okay, there are those that I can engage that can really enhance what we're able to do within our own profession. And that's for all the professions. I speak from my lens of a physician, but for all of us, when we do things interprofessionally and bring those experts in these different areas, it makes things so much better. So I love that. And then you talk a little bit about patient-specific sims and clinical rehearsals. And I'll say I learned so much from your work in that space as well. In my previous role, we looked at your work to then design these clinical rehearsals for very specific patients that we're having. Conjoined twins, it was a very unique surgery they were going to do. And it was really awesome to be able to lean on your work when I was working with folks that were very advanced surgeons and teams that were in this space. And they're like, well, we've done this. But I was like, but have you done this, all combined with multiple teams working together? Let's simulate this. Really, the fact that you added, we didn't do this in our sim, and I hadn't even thought about rehearsing how you updated the family and including family in that. I mean, that is incredible. And I don't know that many people would do that piece.
Yeah, I mean, I think, each situation, patient specific, varies as to whether or not that is the optimal thing to do. But in this particular example, the family was, well, like any family probably would be, very engaged, number one, but also they knew that this was going to be a very long procedure. And there was a lot of complexity in questions that I identified really honestly from talking with the clinicians, like, how are we going to update them? Who's going to update them? How often? And so I said, well, can I reach out to the family? It was just sort of like by happenstance that this happened. It helped a little bit that I kind of knew the patient and family from having been in the NICU, but it also helped that the clinicians kind of identified that this was something they were trying to figure out. And I said, well, simulation is a great way to figure it out. And so
I love that the clinicians identify that. I'm a little surprised, but I love that. I mean, how great that they saw that piece. I know you said this procedure was going to be a particularly long one, and so that they thought about that. I mean, that's step one.
Exactly. Like, were they going to make a phone call? Were they going to go to the room? The parents really wanted to get those updates, and then how often, and we want to make sure it didn't interfere with care. And long story short, I said, well, let me meet with the family and see if they want to participate. And they were 100% did. They were thrilled that they got to be there. So they came in on a Saturday, just like all of the different clinical teams, and they participated in our simulation, and it was great. They had really valuable feedback. And the other benefit of that, just to share this, was not only helping us to prepare for how best to approach this particular surgery, but and including that, patient family interaction, but it also helped them. I think it was like a dry run for them. Yeah. There's a lot coming up to this big, and I remember them saying it just kind of helped them to kind of like go through it even a little bit, to have some sense of what it's going to be like when they're in the real surgery. So I hope that it helped with some of their anxiety.
Yeah, with their anxiety. That's brilliant. It's hard for me to conceptualize things. So something like this would be so beneficial to me. I can plan things like this is going to look like until I experience them. I'm like, oh, that's not at all what I thought, or, and so for me, being able to get in a space and really be like, okay, this is what it's going to feel like. This is how it's going to go would definitely reduce anxiety. So hopefully it did that for that family. And I do remember at the IPSSW conference, you had a panel where you were able to bring in, was it this family or another family that you were able to bring in and kind of have some discussions around involvement in SIM?
Yes. Yeah. This was definitely a different family, not one that I had personally worked with, but they have been big supporters of healthcare simulation at Colorado Children's. And so had a lot of patient experience as well, part of the patient family advisory. And, again, I think one of the things that, I just continue to hear from them in our preparatory call and then in the panel was how much it matters to take the time and to do this work. And it's hard because there's not like a revenue generating component necessarily to this, but it matters to patients and families. And they're
the revenue generating. I think that's hard. In our sim world, that's always a area that comes up, but it truly matters. And I think the other thing reduces anxiety, helps things go smoother, improves trust amongst the team, which is also huge that should matter to the system. It doesn't necessarily bring in money, but maybe long-term, hard to show the connection there, I guess, in research.
Exactly.
Yeah. And then the third one, I want to make sure we have time to get to this third one here too, because, it's dear to my heart too, some EDIA sim. And I think this is a space where partnering with families just makes sense. And yet again, another space where we're not doing this. And I know this is dear to your heart in terms of partnering with families around disability care and care for patients with disabilities. And I know there's just so many gaps, and often we go into this space thinking we know how to fill those gaps instead of asking those that have the experiences. I had a recent experience where somebody was speaking about a medical student who had a disability, and this medical student wanted to go into a specific specialty. And this faculty person said, they just can't. They can't go into this because these are the things they have to be able to do, and they can't with this disease. Which was really interesting was that I could put on two different hats in that moment. And in that moment, the one hat, my typical hat of me as a physician in that specialty to say, they have to be able to do this. And you're right, they can't do that, was my gut. And then I practiced my bias interruption skills and said, let's pause, because I know this is where bias comes in. And I thought, no, the right thing to say is let's ask the student and let's talk about this with the student instead of making a lot of assumptions is what we were doing. And I know you've got experience in that space. I don't know if you want to speak to some of that or even in its intersection with sim.
Yeah, no, I think, oh my goodness, so many thoughts.
No, this could be a whole different episode. I know.
Definitely could be, but in a good way. So obviously, as a person with a disability, I have sclerosplasia, and going into medicine, I wasn't sure if that was a viable option for me. So the story that you share is just, it hits home in so many ways, and it's all too common today. I think the healthcare institutions don't really know how to best support and or manage these complex situations. And yet we know there's the positive. Having individuals with disabilities in healthcare, we know is a good thing. Like there's data to show that they perform equally to persons without disabilities. And there's also data to show that patients may have better compliance with their own care regimens because seeing another person with, especially if it's a similar situation, there's more empathy, more compassion oftentimes exhibited by caregivers with disabilities, meaning healthcare professionals. Having said all of that, there's just a little bit of literature there. There's much more work that needs to be done. The question is, how do you have to look at each individual on an individual basis. So the fact that you, again, Samreen, you are like such an expert when it comes to that lens of equity and inclusion, and I think you paused is going to make a big difference for that student, right? Just the fact that you paused in figuring it out. I think where healthcare is going in this particular space is the concept of talking with the individual, not making assumptions. That's the first thing, which you just described. And then it's also thinking about how do we professionally identify whether or not this is feasible. And so that's where, number one, there's a new profession, disability resource professionals, that have come into play where they can be that liaison between the laws and between the requirements of a specialty and the individual, and knowing a broader breadth of what accommodations can look like for individuals with disabilities. And so having that expert to be that liaison helps to take some of the burden from the individual with the disability, but also brings expertise and provides some, confidentiality, professionalism, and navigates it for everyone. But I think in addition to that, where simulation can help is, when we're not sure whether the individual, right? Like when I was applying to medical school, I had no idea really what challenge I might face because of my disability and how I would overcome them. I had some general thoughts. I have the lived experience. Some like step stools typically are my way to overcome barriers.
Yeah.
Exactly. But there may be other things that I haven't even thought about yet because I haven't been to medical school yet. So that's where simulation can really come in, because we could simulate different accommodations with that individual. Again, not as a test, not to say, oh, you can do it or you can't, but rather let's trial different accommodations and see what works best. And I think that to me is something that we haven't really fully uncovered how to apply yet in our field, that can really help us make our field more diverse, more inclusive, and then support more healthcare clinicians with disabilities so that we can better reflect our population to mirror that of the patients.
Yeah. Oh my gosh. I love that. And I love that you specifically said, I mean, I love all of what you said, but specifically like not to use it as a test, because I could see it being almost weaponized. I think about, you know, all the TV shows where they say if this weapon gets in the hands of the wrong person, right? Like, I think sim is just so incredible, and I would want to make sure it's not weaponized in that way, but rather as a tool to say, okay, let's work on this together, to be able to enable people to say, yeah, actually, I could totally, here's how I would do this in this moment. Let's practice it. And then those that are struggling to be like, well, how could someone do this, can see it too, right? This is incredible, and be part of the solution rather than part of the biased stereotypes front end, you know? So I love that. And I love that you share a little bit about yourself every time you talk about this topic. And that's not easy to do. It takes a lot of vulnerability. And to put yourself in this space to hopefully pay it forward and help make it better for our patients and families is so important. I'll plug that, you know, for another bias interruption strategy is counter stereotypic imaging, where you deliberately, when you have a bias about something or you think there could be a potential bias in a space, you deliberately think about people that counter that bias. And so, you know, I think, Dr. Arnold, you're going to be the person that people should think about when they have to counter that bias. And I'll tell you, in that instance, in the situation I was in, that is actually, and I had another colleague who also knows you and also knows a couple other folks in this space with disabilities that are in the medical field. And that's what they used to say. They did counter stereotypic imaging for the other faculty that brought this up. So, I mean, you are having an impact in all the spaces you may not know about. Dr. Arnold, you're impacting the world, and in your work is really changing lives and saving lives in all these different spaces. So as you said, having people with these diverse backgrounds not only is just, hey, they're here, but it completely changes and improves everything that we're able to do. So I think that's really cool. Yeah.
Thank you. You make me cry.
Well, you're amazing. And so you should don't cry, but I'm really excited to be learning from you. And I know we talked a little bit about this space being a difficult one because it does cross into personal experiences, you know, simulation. We've always felt like we do it for learners. We're like, it's really important. And then when SIM moved into this quality and safety and patient experience, patient safety space, there was a little more urgency because then we could see right at the bedside. Oh, and now as we move into this EDIA space, there's even more urgency. And then there's this personal aspect. And so that changes things.
Yes, no. I mean, for me, every time I've now had the opportunity to get more involved in disability, health equity, and just in my work, both in SIM and outside of SIM. And it's so exciting, but it's also, it's invigorating. It's energizing because finally there's interest in this. And, you know, when I was going to apply to medical school, I just put my head down. I was like, ignore the disability.
Aww.
Just say, don't talk about it. It's obvious. Like mine is not a non-apparent disability. So I have to talk about it in the room, so to speak, and address it. But at the same time, I wanted to prove that, you know, it didn't matter, so to speak. But now it's like, okay, I can sort of say it matters, but in a good way. And it's invigorating from that space that the people are interested in talking about it, just that piece. But at the same time, as you start to see the potential for where we could go and how much better we could make things, both for our patients and families from a health equity lens and for healthcare clinicians who are serving our patients and families, it's almost deflating as to how, like, it's like hard to have happen quickly enough because it's way overdue. It's way overdue.
Yeah.
I mean, we think about just like so many other marginalized populations we now know, which I didn't know when I was, you know, younger in my career because no one was really talking about it. But now we know that just because of disability, our patients have worse healthcare outcomes, right? They suffer healthcare inequities. And I think for a long time, people sort of said, well, it's because of the disability, right? That they're having, no, it's because of their medical problems, right? But it's not, it's actually because of bias. It's because of structural alcoholism that our patients and families don't experience the same outcomes that they could or should. And it's like so exciting to be a part of the change, but it's like, come on, let's keep it going.
It's not fast enough.
Not fast enough, yes. So I'm trying to keep my enthusiasm at bay.
Yeah, you got to find that balance. And I love how you describe that. This work in this space can be deflating and energizing all at the same time. And you have to find that balance so that you can keep going, otherwise you get burnt out or you feel like it may be impossible because some of the gaps we see are just so huge. And you think about, oh my gosh, like these have been around for so long and we're still trying to work on, making a dent in these gaps. And my work has been more focused on, it's actually all biases, right? And thinking about bias interruption skills, because it really in ableism, racism, kind of in sexism and all of these spaces they apply when you can really use these bias interruption skills. And when you think about racism as one of those, right? You think about the number of years we have spent learning about disparities over and over and over. It just feels really urgent to start making that impact or continue to make that impact that others have already started and bring simulation into it because it's such a powerful tool. So I know we've been talking for some time, so I'm going to maybe wrap us up here just on that note. Simulation is this really powerful tool, and the way you've given a framework around using simulation to enhance patient and family-centered care is incredible, and the opportunity to really grow in learning more and folks really diving deeper and doing more research and growing the literature in this area, I think will be critical. Is there anything that we haven't really, I know we could talk forever, so probably there is, but anything we really want to add in here at the end that we've missed?
Oh, no, I think we talked all about some of my favorite topics. And like you said, we could keep talking forever. And Samreen, I always enjoy talking with you. So I'm super appreciative of the opportunity to talk about my passions with you. And I'm really excited for this podcast. Like, it's great. Our community needs it. So it's really great.
Thank you, Dr. Arnold. And thank you to everybody else for joining us today.
Thank you for listening to this episode of the IPSS podcast. A special thanks to our behind-the-scenes producer, the talented Denish Kumar, and to the Starship Foundation for providing the equipment that makes this podcast possible. Join us next time.